Okay, good morning, everyone. Thank you very much for coming to this talk on about pain management and ways of which we can try and work towards helping some of the patients and the people that we treat. My name is Nafis Anjarwan. I'm president of the Society of Back Pain Research, and moderating with me is going to be Karen Wellington, who is one of the executive members of the same society. We're very lucky to have three distinguished speakers who are going to help us with this particular session. We have Mr. Ganesh Bharani, who is the president of the Neuromodulation Society of the UK and Ireland and is an expert on spinal cord stimulation based in Leeds. We also have David Hughes, who's a senior lecturer from Glasgow, where we had thought at one stage we might actually be, and is a leading expert on pain circuits within the spinal cord. Whitney Scott is a psychologist who is a lecturer of clinical psychology and is one of the leading members of the Input Pain Management team at Guy's and St Thomas's. We're going to have all three talks first and then go through the questions afterwards. And without further ado, I will start the first talk.
Good morning. I'm Dr. Ganesh Bharani. I'm one of the pain consultants at Leeds Teaching Hospitals. Thank you for inviting me to talk about spinal cord stimulation. These are my disclosure slides, and I'll leave this for a few seconds. So in the next 15 minutes, my plan is to talk about the history of spinal cord stimulation, what has happened to the field in the last 10 years, the evidence base behind the use of spinal column stimulation, a real-world data of using a national neuromodulation registry, and how can you refer patients for this therapy. So electrical stimulation goes back to 46 AD when people used the electric eel to treat pain. So they used to tie them in the forehead for migraine, and they used to stand on top of the electric eel to try and get some pain relief from sciatica. So these have been described, and there was a sudden boom in use of electricity during this period. And in the 19,000, there was a ban on use of electricity without any proper studies. And hence, I think this has been dormant for quite some time until Melzack and Wall gave the gate control theory, and the rebirth of spinal column stimulation or electricity used to treat pain has come into play. So what is neuromodulation? We are trying to modulate the nervous system, be it using chemicals or physical. So if you think about a painful stimulus, this has to pass through a spinal cord into the brain and you get pain. And we're trying to process this at the spinal cord level using electricity to try and treat pain. The spinal cord stimulation implant consists of an electrode placed in the epidural space, which could be either a percutaneous electrode placed using a needle, or it could be a paddle lead, which is placed by either a laminotomy or a laminectomy, which is then anchored and connected to a battery, and this battery powers the system. So this is pretty much similar to a pacemaker for pain. How does it work? I'm not going to go into the details of mechanism of action. I'm more interested in talking about the stimulation parameters that we use. One is amplitude, which is the amount of electricity used to stimulate the spinal column or the dorsal column. Two is the frequency at which the electricity oscillates. So in essence, we used to use 40 hertz to 60 hertz, and that's the number of times the electricity oscillates within a second. And a third one is a pulse width, where how wide the pulse goes in to stimulate the various parts of the dorsal column. So these are the three parameters where we could actually manipulate and stimulate the spinal cord stimulation. The commonly used stimulation parameters are approximately 40 to 60 hertz and a frequency of, and an amplitude anywhere between 4 to 8 milliamperes, depending upon the electricity needed per patient. So the first randomized control study was done in early 2000s, where they looked at patients who had previous back surgery comparing them with medical management alone and a group consisting of spinal cord stimulation plus medical management. And the active group or the active treatment group was followed on for 6 months, 12 months, and 24 months for pain, health-related quality of life, medication use, function, and complications. So these are the results. So the 6 months results showed that there was about 48% of people in the SCS arm had more than 50% improvement in the leg pain. And this equates to an NNT of 2.56. Why leg pain? Because normally when we use paresthesia-based stimulation, especially when the patient is feeling a tingling sensation, we find producing the same tingling sensation in the back on a longer period is difficult, because as the back fibers are deeper in the dorsal column, you need higher amplitudes to achieve that, which then becomes more painful in the leg. So around 2000s, we were using predominantly for patients who have sciatica or nerve root pain as an indication. This was then followed up for 24 months, and they showed there was a nearly 40-odd% of patients who maintained the pain relief at 24 months. This was the key paper that was used in NICE TA159 to approve the use of spinal cord stimulation for failed back surgery syndrome. But this is also available for other neuropathic conditions to treat other chronic neuropathic pain conditions. So what changed? Around 2012, a company came in with ability to do 10,000 hertz. So you're talking about a frequency jump from 60 hertz to 10,000 hertz. And the general theory is if you use at that high frequency, you could have a complete conduction blockade. But this wasn't true when they did the initial studies, which was then followed up by another neurosurgeon in Belgium who came up with the idea of using burst stimulation. Burst is pockets of stimulation, which then have a 4-pocket or 5 pockets, which then has a frequency of about 40 hertz and sends it in a burst way. And this is similar to what our current body communications happens from the peripheral nervous system to the central nervous system. The only difference between the device, which is regular, to our human body, which is irregular. So what's the advantages of paresthesia-free systems? So this HF10, or the high-frequency 10 kilohertz stimulation, was performed by placing these electrodes anatomically at T9, T10 disc, and was able to provide programming where the patient does not feel any paresthesia and still achieve pain relief. The first cohort of patients was done between London and Brussels, and these patients were approximately 80 in the group, which showed a very promising result, not only for leg pain, but also for back pain. This then transpired to a big randomized controlled study looking at one arm where the HF10 was used, or the 10 kilohertz was used, and the second arm where the control arm where the traditional spinal cord stimulation was used. At the end of 24 months, they found the responder rate, which is people who had more than 50% improvement in pain on the HF10 arm for back pain, was 76%, comparing to the conventional paresthesia-based SCS system, which was 49% on the control group. This again was similar for leg pain, so 73% on the HF10 arm and 49% on traditional SCS arm. So if you compare this with the process study, this is close enough to similar results that they produced in 5 months period for the conventional traditional SCS arm. So this was exciting, obviously, because all of a sudden from a paresthesia-based system, we were able to move into a non-paresthesia-based world. The advantages of burst was postulated based on some functional studies and also from EEG studies. Is it does not only work on pain pathways, but it also works on the emotional component of the pain. So in essence, the patients can feel the pain, but they don't bother about it as much. And that was the theory of using burst. We then had another company which came up with the idea of saying, right, what are the disadvantages of paresthesia-based system? The paresthesia-based system, every time you lie down, cough, sneeze, your electrodes come closer to the dorsal column, producing unbearable stimulation. So the patients tend to turn it down so they don't have the required amount of stimulation to the dorsal column. So this company came with an ability to measure the ECAP, which is the evoked compound action potential. And for every beat, they're able to adjust the electricity so they can keep the therapeutic stimulation in the same window. For example, heart rate variabilities, coughing, lying down, standing. And they have done a study proving that this modality of treatment, which is a low frequency stimulation, still works as good. So this has been published. So the evoke study was the one which looked at the closed loop. This has been published in Lancet, and this has 93% responder rate. We also have Sunburst study, which is looking at the use of burst for managing the pain. And this, again, has high responder rate. One of the things that we're currently working on is also to change the terminology from failed back surgery syndrome to persistent spinal pain syndrome. But this is in the pipeline, and hopefully we should see this PSPS in the near future. What about patients who've not had an operation in the past? Because they don't have a surgical target, but they still have significant back pain. You're probably seeing these patients regularly in your clinic. Some of them have neuropathic features where they explain burning, stinging, and when you do examine their back, they have hypersensitivity present. And some have a typical mechanical facet-related pain, and there are low back pain guidelines for medial branch block and radiofrequency denervation. So Guy's and Thomas has conducted a prospective case series of 20 patients selected with predominant back pain who have not had any previous surgery, and they were able to show that the back pain and the leg pain, predominant back pain was the key inclusion criteria, from approximately 79 millimeter, we're able to reduce it down to 10 millimeters. We in Leeds performed the same, but the only difference with us is we documented the hypersensitivity in the back using skin prick and touch sensation. And we published our 1-year results, which clearly shows that the pain reduction is significant. The quality of life improvement is also quite good, and the ODI scores improve significantly. Now, this has been studied in much bigger RCTs. There's one RCT going on where the stimulation is compared with conventional medical management. In the other one, where there is a placebo arm. So we have one electrode in the epidural space and the second electrode in the subcutaneous place, trying to stimulate without the patient knowing. And the results are awaited. So what about muscle dysfunction? I think this is looking at multifidus muscle. You might have seen these MRI scans in some patients with significant fat infiltration into the MRI, into the muscles. The question is, in some patients, they have a principal injury. They get better with physio, most of them, and some don't. And that's because they probably lost the neural drive to rehabilitate this muscle. So we developed the system, and I think I was one of the few people who got involved right at the beginning, where we stimulate the L2 medial branch at the L3 vertebral process. This is selected because this seems to stimulate all the groups of multifidus muscles, the superficial, deep, and intermediate. And we showed 204 patients were randomized. The average age group of young, as you'd expect, 47. They started off at the pain score of about 7.3. And we showed that there was a significant reduction at 24 months to 2.5 and an improvement in ODI by 50%. So when you look at this, these are the patients where they were at the severe to moderate level. And after the treatment, they actually dropped down to mild criteria. What about the real life data? So if you look at the national database, we've collected more than 3,000 patients in our database, of which 1,100 has back pain as a predominant reason for pain, of which 96% of these patients had back surgery before. This is the quality of life improvement preoperatively from a mean of 0.26 to a mean of 0.49. And there's an improvement in the EQ5D of more than 0.2, which is significant. What about the patient satisfaction? As you can see, the significant amount of patients are highly satisfied with the treatment. So how do you actually know who to refer? This is an online tool that we developed where you can actually go in and register yourself. It's called scstool.org. Once you register, you go in and you look at the inclusion criteria. These are the common conditions that we use spinal column stimulation for. And the exclusion criteria, such as the patient's unwilling, can't manage alcohol abuse or drug abuse. Then you go in to the next step, selecting the indication. If it's back and leg pain, do they have previous surgery? Is it back or leg, or is it neuropathic or nociceptive? Is there any scar tissue, or is it iatrogenic nerve injury? And what happens if you do a nerve block, if you put them on antineuropathic drugs? Based on this, you can actually look at the appropriateness of SCS. And this would clearly show that the patient can be referred. And the next step we look into further is your engagement, coping strategies, expectations, activities of daily living, social support, gain, secondary gain, psychological problems, and high-dose opioids. When patients have these things looked into, we can optimize them with an MDT management and address these issues before we implant with spinal cord stimulation. This has been published. It is also available in various languages, and it's free to use. So in summary, I've talked about use of spinal cord stimulation as an evidence-based therapy. This is also cost-effective therapy, and consider early and obviously think about this in even patients who are not suitable for surgery as an option of treatment. There are more than 35 centers in the UK and Ireland, UK and Northern Ireland, and you can find out what is the closest center to you to make these referrals. Thank you.
Thank you very much, Bharani. So we're now going to move on to the second talk, which is going to be given by David Hughes.
My name is David Hughes. I'm a senior lecturer in anatomy at the University of Glasgow and a principal investigator at the university's Institute of Neuroscience and Psychology, where my research aims to improve our understanding of the spinal cord circuits that are involved in somatosensory and visosensory processing. I'm delighted to give this presentation today at the BritSpine meeting on spinal cord circuits underlying acute and chronic pain states. In this image, we've taken a section of the mouse spinal cord and stained it with an antibody that labels all neurons. The cell bodies of these neurons can be seen in blue here. And the first thing that we notice is there are quite a few of them. To be able to understand how these neurons are involved in sensory processing, we need to learn a little bit more about them. What we need to do is to be able to define these populations on a whole series of different defining characteristics. And these can include the morphology of these cells, the synaptic connectivity of these cells, their electrophysiological properties, their molecular genetic properties, and also their neurochemical features. Now, using these defining features, we can add these populations to the basic template of the spinal dorsal horn, where we have nociceptive afferent input being relayed into the most superficial laminae of the spinal dorsal horn and engaging with pain circuits within that region. Low threshold mechanoreceptive input is relayed into the spinal cord by these myelinated low threshold mechanoreceptors, and these will terminate and arborize within deeper dorsal horn laminae in laminae 2 inner, 3, and 4. Now, under normal circumstances, there is a robust segregation of activation of pain circuits from those of low threshold mechanoreceptive afferents. But under pathological conditions, for example, peripheral nerve injury leading to tactile allodynia, this segregation is lost, and the recruitment of low threshold mechanoreceptors can lead somehow to the aberrant activation of pain circuits in the more superficial laminae, leading to mechanical hypersensitivity or tactile allodynia. Precisely how this happens remains a question that we're trying to address within my lab and various other labs throughout the world. One population of nerve cells within this region that are thought to have a very important role in the development of allodynia are inhibitory interneurons. And this was demonstrated by work from Tony Yaksh, where he was able to administer antagonists to glycine and GABA in experimental rats, and this led to the development of organized agitation responses to light tactile stimulation, which is very similar to the presentation of tactile allodynia that we see clinically in patients. Now, how can we actually restore normal somatosensory information processing? Remains a major challenge. And we've already seen the relatively widespread use of spinal cord stimulation to alleviate these chronic pain conditions. But the question remains is what populations or populations of cells are actually recruited using these approaches? Now, this is a question that was posed in a recent review by Melanie Jensen and Rob Brownstone, and they used data from basic animal research to propose that the recruitment of a circuit involving a population of inhibitory interneurons known as islet cells, and also the involvement of a population of glutamatergic or excitatory interneurons known as vertical cells could be a key circuit that was activated as a result of these electrical stimulation properties. Now, these populations of cells have been reported in animal species, in a whole series of species, including rats, mice, cats, and hamsters, but they've also been reported within the human spinal cord, even as far back as the work of Santiago Ramon y Cajal, who recorded the presence of limitrof cells, which have now been renamed as vertical cells. But also in the work of Stefan Goebel, who has identified these vertical cells as well as islet cells within the spinal cords of cats using the same staining techniques as Cajal had used. And using these Golgi staining techniques in human spinal cords, Shonin was able to demonstrate the presence of vertical cells and islet cells. So we know that these two populations are conserved within various animal species. Questions posed by the review from Jensen and Brownstone was that it was not clear what the targets of islet cells were, nor the type of inhibition that these inhibitory interneurons mediated. Was it presynaptic inhibition or postsynaptic inhibition of dorsal horn interneurons? They conclude that what we need to do is to have further information of the synapses formed by islet cells, so we can then understand the roles of these neurons in the development of neuropathic pain states. Well, since the aim of research within my group is to define functionally distinct circuits, we've been lucky enough to actually identify two functionally distinct populations of islet cells. Now, islet cells are defined on the basis of their morphology, in that they have an extended dendritic arbor that's orientated along the long axis of the spinal cord. So the dendritic arbor will project in a rostrocaudal direction along the length of the spinal cord. These inhibitory interneurons all contain GABA, but some will also contain the inhibitory amino acid glycine. And these inhibitory interneurons are able to mediate both presynaptic inhibition of primary afferent fiber central terminals, as well as mediating postsynaptic inhibition of other dorsal horn interneuron populations. To explain what presynaptic inhibition is, in this animation, what we have in red is the representation of a sensory afferent projecting from the periphery and forming a central synapse within the spinal cord. This synapse is onto a second order sensory neuron and is responsible for relaying this afferent input to higher centers along functionally distinct ascending sensory pathways. Now, when we activate the peripheral ending of the sensory neurons, that can lead to the generation of an action potential, which is conveyed along the peripheral axon, to cause the central release of glutamate and the activation of these ascending sensory pathways. Within the spinal dorsal horn, there are populations of inhibitory interneurons that form axo-axonic synapses, where the release of GABA will cause primary afferent depolarization, and this opposes the incoming action potential along the sensory afferent to block synaptic transmission at the first synapse. What we believe is that in pathological conditions, the inhibition lost are mediated by these axo-axonic cells is lost, and that results in the aberrant relay of afferent input into the spinal cord and the aberrant recruitment of central pathways. The first population of cells that I would like to describe are those that express the calcium binding protein parvalbumin. Now, these cells are found principally within lamina 2 inner and lamina 3. You can see these bright green dots being the cell bodies of the individual nerve cells, but their axon terminals are found primarily to arborize within lamina 2 inner. And these axon terminals form axo-axonic synapses onto the central terminals of myelinated afferent fibers. These parvalbumin inhibitory interneurons have very defining electrophysiological properties in that they tend to show either tonic firing or initial bursting firing action potential discharge patterns in response to current injections. And what we found is that their principal afferent input is derived almost exclusively from myelinated low threshold mechanoreceptors, and that the targets of these inhibitory parvalbumin interneurons will be the same types of central terminals from myelinated afferents. So they inhibit the type of afferent input that recruits them in the first instance. They will also inhibit distinct types of dorsal horn interneurons, and these include vertical cells, which are themselves responsive to afferent input from low threshold mechanoreceptors. But under normal conditions, the inhibition mediated by parvalbumin cells prevents the relay of this low threshold input through vertical cells to pain projecting neurons in the superficial layers of the dorsal horn. However, following peripheral nerve injury, the inhibition mediated by parvalbumin cells is greatly reduced. And as a result, these cells are unable to mediate presynaptic inhibition of the low threshold mechanoreceptive afferents. And likewise, they're unable to mediate the postsynaptic inhibition onto distinct dorsal horn populations, including vertical cells. This opens up the polysynaptic route whereby low threshold mechanoreceptive inputs can be relayed through disinhibited vertical cells to result in the activation of pain projecting neurons. And this is a direct pathway that can lead to mechanical hypersensitivity or tactile allodynia. The importance of these parvalbumin interneurons has also been demonstrated in work from Reza Sharif Nayeni's group at McGill University, where they were able to manipulate the activity of these inhibitory interneurons using optogenetics to silence them, and that resulted in the development of mechanical hypersensitivity. And in animals that were already showing signs of tactile allodynia, they were able to use a chemogenetic approach to restore the activity of these inhibitory interneurons. And that resulted in a shift in mechanical sensitivity back to more baseline levels. The second population of inhibitory interneurons I'd like to speak about are the calretinin expressing spinal interneurons. These interneurons, shown here in green, are found to be highly densely congregated within lamina 2. And for a number of years, calretinin expressing cells were thought to represent a population of excitatory interneurons. When we started to study them, we patched them using whole cell patch clamp approaches and labeled individual nerve cells using intracellular labeling approaches to recover the morphology of these cells. And what we found is that there's a whole range of different morphological properties that we find within these calretinin neurons. However, closer inspection of this population using a marker for inhibitory interneurons led us to the conclusion that approximately 15% of these calretinin cells were inhibitory interneurons. And indeed, all of these inhibitory interneurons displayed islet cell-like morphologies. When we looked more closely at these islet cells, we found that they gave rise to axonic synapses onto the central terminals of mechano-nociceptive afferent fibers, and that when we manipulate the activities of these inhibitory interneurons specifically using optogenetic approaches, we find that they mediate presynaptic inhibition of C-fiber afferent inputs. In conjunction with work from Kim Chisholm and Stephen McMahon at King's College London, we were able to show that these populations of islet cells were also responsive to noxious mechanical stimulation using real-time calcium signal imaging in vivo. And essentially what we're able to do is to load these cells with a fluorescent molecule which will fluoresce under recruitment of these cells and apply noxious peripheral stimuli in a thermally anesthetized mouse. And what we see is that each time a pinch is applied in the periphery, these cells receive afferent inputs from those nociceptors and are recruited. And you can see the elongated dendritic arbor of these cells, confirming the morphology of this population. So my take-home messages from this presentation is that there are two distinct types of islet cells that we can define on the basis of their location within the spinal dorsal horn, on the basis of their physiological properties, and also of their molecular genetic profiles. The first are the parvalbumin expressing cells, which are found relatively deep in the spinal dorsal horn, principally in lamina 2 inner and lamina 3. These inhibitory interneurons play a very distinct role in modulating the activity of central terminals of low threshold mechanoreceptors. And the inhibition that they mediate is important because if we lose it, that can lead to the development of tactile allodynia. The other population of cells that we've spoken about are the calretinin expressing islet cells. These are found more superficially within the dorsal horn. These are found in the middle lamina 2, and they modulate the activity of central terminals from mechanoreceptors, which leads us to the conclusion that the loss of inhibition mediated by these cells can lead to the development of mechanical hyperalgesia. So we have two very distinct neuronal populations that modulate and gate two very different types of afferent inputs, and the loss of inhibition mediated by these cells can lead to very distinct types of chronic pain. The principal take-home message that I have is that studies in animal models provide an accessible means of testing various types of scientific predictions. In this case, that selective neuronal recruitment can restore normal function. And this can act as a first step in optimizing clinical practices. Continued use of animal models will provide further insight into neuronal basis of somatosensory processing. And this can be important in identifying distinct neuronal populations, which will allow us to develop novel pain treatments. I'd like to acknowledge the contribution of several individuals in these two projects, principally Kieran Boyle from my lab in Glasgow, who's worked extensively on the parvalbumin story, but also significant contributions from Andrew Todd, Marami Mustapa, and Olivia Davis on the story on the inhibitory calretinin cells. Both of these projects have been carried out in collaboration with my principal collaborator, Brett Graham, based at the University of Newcastle in Australia. And there have also been significant contributions from David Ginty at Harvard Medical School, and both Steve McMahon and Kim Chisholm from King's College London in the UK. I would also like to acknowledge and give my thanks to the BBSRC, the NHMRC from Australia, and the NC3Rs for supporting work in my group, and I'd be happy to take any questions. Thank you.
Thank you very much, David. That's brilliant. I'm now going to present the last speaker of this session, Dr. Whitney Scott. Thank you very much, Whitney.
Hi, everyone. I'm Whitney Scott. Today, I'll be talking to you about acceptance and commitment therapy for chronic pain, looking at evidence and innovations. This is a brief talk, so I'll start from the assumption that people recognize that pain and pain-related disability are biopsychosocial phenomena. We know that pain is not just a physical sensation in the body, it also has cognitive, emotional, and behavioral components and occurs in a social context. Psychosocial factors such as appraisals of the threat value of pain, anxiety, depression, and social support all play an important role in pain chronicity and in pain-related disability. Cognitive behavioral therapy, or CBT for short, is the most widely researched psychological treatment for chronic pain. Briefly, traditional CBT focuses on pain education, identification and reappraisal of unhelpful pain-related thoughts, exposure to feared situations, and the development of coping skills. A recently updated Cochrane review of psychological treatments for chronic pain identified 59 randomized control trials of CBT compared to an active or inactive control. Meta-analyses included over 5,800 participants with a range of pain conditions. And the authors of this review found evidence of small effects of CBT on pain intensity, disability, and distress post-treatment, and small effects on pain and distress at follow-up compared to treatment as usual. There were very small benefits for all outcomes compared to active control at post-treatment, and very small benefit for distress at follow-up compared to active control. And in general, just to say, we tend to see slightly bigger effects of CBT for distress and disability compared to pain intensity. So evidence supports the use of CBT for chronic pain, although impacts are modest and there is certainly room for improvement. Acceptance and commitment therapy, or ACT for short, is a newer form of CBT and can be differentiated from traditional CBT through its basis in the psychological flexibility model. Very briefly, psychological flexibility is the capacity to experience pain with openness, to consciously focus on experiences like pain in the present, and to consistently pursue valued activities. We can describe this as well as behavior that's open, aware, and engaged. As applied to chronic pain, the psychological flexibility model assumes that psychological flexibility is the key process that mediates between the experience of pain and related thoughts and feelings, and functioning and quality of life in people with chronic pain. The concept of pain acceptance is linked to psychological flexibility and describes stopping efforts to control pain when those pain control strategies don't work or when they create additional problem in a person's life. Pain acceptance also describes a willingness to experience pain so that meaningful life activities can be pursued. So briefly, ACT aims to help people improve engagement in meaningful life activities in the presence of pain and related thoughts, feelings, and memories, rather than symptom reduction. ACT is a process-focused therapy, which means that it's primarily focused on targeting the key process of psychological flexibility, which is assumed to influence treatment outcomes. Treatment methods are flexibly used to target this process, and some common methods include the use of metaphors, experiential exercises, and these really help people to connect with the functions of their behavior and to alter the functions of unwanted experiences on behavior. We also use mindfulness exercises to enhance present moment awareness and help people to clarify deeply held personal values and then set goals and take steps in line with those values. A 2016 systematic review by Vhoff and colleagues identified 25 RCTs of ACT or mindfulness-based treatments with over 1,200 participants. Compared to inactive controls, ACT and mindfulness treatments showed small effects for pain intensity, disability and depression, and medium effects for anxiety and pain interference at post-treatment. At follow-up, the effects compared to inactive controls were small for pain intensity, medium for depression, anxiety, and disability, and large for pain for pain interference. There was no difference between traditional CBT and ACT, which is largely consistent with the broader psychotherapy literature. Just to say that the 2020 Cochrane review that I just mentioned only included 6 RCTs of ACT, as that review required a minimum of 20 participants per arm. And that review concluded that there is very low quality evidence for ACT and the uncertainty about the estimates of ACT effects. However, that review didn't include trials of online ACT for chronic pain, of which there's a growing number of larger studies now. And they also didn't include trial designs such as non-inferiority trials or those in which ACT was delivered by non-psychologists. So certainty in the efficacy of ACT for chronic pain will increase as this body of evidence grows. Moving on from RCTs now, I'll present observational cohort data from patients completing interdisciplinary ACT-based treatment at the Input Pain Unit at St. Thomas's Hospital in London, where I'm based and work clinically. Patients completing treatment in our service routinely complete a set of standardized self-report questionnaires before and after treatment and consent for the data to be used for research. The data for the study on the slide here are from 354 patients completing treatment between June 2016 and September 2017. The program consisted of 15 to 16 full days of group-based residential treatment over 3 or 4 weeks. Treatment was based on the ACT model I just described and was delivered by psychologists, physiotherapists, occupational therapists, and nurses. Participants were eligible if they had pain longer than 3 months that was associated with significant functional impairment or distress as judged during the interdisciplinary assessment. At the start and end of treatment, participants completed measures of demographics, pain intensity, pain interference, and that was on the brief pain inventory, and depression symptoms using the PHQ-9. We were also interested in seeing whether comorbid fatigue impacted on treatment outcomes. So we assessed fatigue interference using the fatigue severity scale. Almost half of the sample, just to say, reported chronic back pain, and a third reported widespread pain. 80% of the sample also reported clinically meaningful levels of fatigue on that measure I talked about. Looking from pre to post treatment, we observed large improvements on pain interference and depression symptoms. We saw small to medium improvements on fatigue interference and pain intensity. And the analyses indicated that people with and without elevated fatigue at baseline benefited equally from treatment. So these data support the potential effectiveness of ACT in real-world practice for people with pain and comorbid fatigue, although it's important to emphasize that there was no control group, limiting conclusions we can make about the causal impact of treatment. In addition to the intensive ACT-based program I just described, our service also offers a similar program specifically for people on the pathway to receive spinal cord stimulation. This neuromodulation program consists of 10 full days over 2 weeks with the same team of clinicians I described on the previous slide. The aim of the treatment is to improve patients' physical and emotional functioning and to leave them in a better position to benefit from subsequent neuromodulation. The 2-week program is completed prior to deciding, in collaboration with the patient's neuromodulation consultant, whether they want to proceed with trial implantation. So in addition to the ACT principles and methods I've described, the program also focuses on giving information specifically about neuromodulation and helping patients to make a fully informed decision about this treatment. And I'll just say now that the data for the study I'm presenting are from a while back in 2012 and 2013, and we were running this program in a similar manner up until the beginning of 2020 before the pandemic, and we've since adapted this program for remote delivery because of the pandemic. So for this study on this slide, participants completed measures of functioning, in this case the SF-36, again of mood, so the PHQ-9, and pain acceptance before and after treatment. Medical records were reviewed to obtain patient outcomes related to spinal cord stimulator implantation following the program. And these outcomes included whether they went for trial implantation, whether that trial was successful, and whether they received the full implantation. Trials were deemed successful if patients received at least 50% pain reduction, the stimulator provided sufficient coverage of the pain area, and the leads remained in place during the trial period. The sample for this study consisted of 86 patients deemed medically suitable for spinal cord stimulation. and 85% of these reported low back and leg pain of long-standing duration, and the sample was predominantly white. We observed pre to post treatment, moderate improvements in physical and social functioning, depression, and pain, and a small improvement in pain acceptance, and all of these were statistically significant. 77% of patients went on to receive the trial implantation, and 70% of these trials were deemed successful and followed by a full implant. Of the 23% of patients that didn't proceed to the trial, 2/3 did not do so at the consultant's request, while 1/3 did not receive the trial due to their own choice. And those who didn't proceed to the trial reported worse depression and lower pain acceptance at the end of the 2-week program relative to those who did go for the trial. Again, with the caveat that this was a relatively small and uncontrolled study, the data suggests that people seeking medical interventions primarily focused on pain reduction can also benefit from an interdisciplinary treatment focused on pain acceptance to improve daily functioning and mental health. And we continue to collect data for participants completing our virtual neuromodulation programs, and hopefully can report these in the not too distant future when we have sufficient numbers. So now just moving on to a slightly different area. So we know that there are significant issues in accessing psychologically informed treatments for pain, and ACT-based treatments for pain tend to be delivered in highly specialist centers with resource-intensive models. So there's certainly a need for more cost-effective and accessible delivery options, and there's a growing body of research suggesting that psychological treatments can be delivered over the internet. As part of my postdoctoral fellowship, funded by the International Association for the Study of Pain, and in collaboration with Professor Lance McCracken, we developed a therapist-supported version of internet-delivered ACT for people with chronic pain. And this consisted of an initial and final telephone call or face-to-face visit with a psychologist, and followed by 8 online treatment sessions that consisted of pre-recorded videos guiding participants through a variety of ACT exercises over 5 weeks. And during treatment, participants completed or answered several questions after each session to reflect on their experience practicing the exercises. And their therapist provided support through feedback messages after each session. And we conducted a feasibility RCT as an initial evaluation of the online ACT program and to determine the feasibility of a larger trial. So we recruited 63 participants of 135 referrals from the St. Thomas's Pain Center between September 2015 and June 2016. Participants were randomized to online ACT plus standard medical care in our pain service that was consultant-led, or standard care alone in a 1-to-1 randomization. Participants had chronic pain of clinically significant intensity and interference, as well as distress, but no active psychological risk, and they were able to use and access the internet. Participants completed self-report measures at baseline and 3 and 9 months post-randomization. And the primary outcomes, because this was a feasibility trial, included recruitment, retention, and treatment completion rates. Secondary outcomes were global impression of change ratings and changes in functioning, mood, and psychological flexibility. For the results, we recruited 63 participants, as I said, and we had a retention rate of 76% at follow-up, which was just below the accepted standard of 80%. 61% of participants were regarded as treatment completers, which was 9% less than our a priori target of 70%. In terms of the global impression of change rating, 56% of participants in online ACT rated themselves as much improved or very much improved overall, versus just 20% in the control condition. We observed small to medium effects favoring ACT online for mood and disability at 3 months, and the effect for disability was maintained at 9 months. The results suggested that online ACT for chronic pain may be feasible to study in a larger efficacy trial with some adjustments to treatment and trial procedures to improve recruitment, retention, and treatment completion. And just to say, so there's now been larger RCTs supporting the efficacy of online ACT for people with pain by other research groups. And to improve the flexibility of delivery and the available treatment options within our service at the Input Pain Unit, We've actually implemented this online ACT program since 2018 as a treatment pathway. The online ACT program has allowed us to continue some service provision in the early months of the COVID-19 pandemic when in-person services were stopped. Just important to keep in mind that our online ACT program is primarily self-directed with minimal therapist support and is unlikely to meet the needs of people with more complex presentations that previously required our intensive residential treatment. So following the pandemic, after a few months, our service developed and implemented a more intensive virtual pain management program delivered live via a video platform to meet a greater complexity of need. And our service now uses multiple kind of virtual and online pathways, and our lower intensity online ACT program now runs as another pathway alongside those virtual, more intensive programs. In summary, and to conclude, ACT appears to be a beneficial approach for managing the impact of chronic pain. And to advance our understanding of this treatment approach, future research is needed to investigate who is most likely to benefit from ACT in various delivery formats, such as online. We also need to explore how we can more broadly implement ACT for pain outside of highly specialized pain clinics and to better investigate treatment mechanisms. Thanks so much for listening. I look forward to our discussion.
Thank you very much to all our speakers. Karen, questions, please. Karen may well have dropped out. She's been having some Wi-Fi problems. So I'm going to ask a question which is to David, please. One of our colleagues has commented, you've identified various islands of cells which are quite close to the dorsal which are in the posterior aspects. Do you think that we should be considering surgery sooner rather than later to try and preserve these inhibitory cells? And do you think that damage to this population is what often causes chronic pain? So leading on to the next question, has there been any investigation post-mortem of patients with chronic pain to see whether or not these islands are actually damaged as a cause for the symptoms that the patients were complaining of?
Comes for global impression of change ratings and changes in functioning.
That wasn't me. Can you hear me, Nafis?
I can indeed. Thank you.
Yes. Okay. Right. Thank you for those questions. The first question relating to surgical procedures, I don't know what we can actually do surgically to try and restore the normal function of these cells. It appears in our animal models that after peripheral nerve injury, the cells don't die, so they're still there. They still make their usual connections, but being able to actually recruit these inhibitory interneurons becomes much more difficult. And if we can't recruit them, they can't mediate the type of inhibition that they would under normal circumstances. And that makes their targets more excitable, which leads to the prospect of aberrant sensory processing within the spinal cord. So I think the aim is to actually try and restore the normal function of these cells, and using electrical stimulation may indeed be one such way. I think the animal models can maybe try and give us a better handle on precisely which stimulation parameters that we need to recruit these types of interneurons to actually restore particular types of behavioral changes. So, for example, if we can selectively recruit the parvalbumin expressing islet cells, that can maybe help restore tactile allodynia. Whereas if we use slightly different parameters to recruit the calretinin expressing islet cells, which are more superficial within the dorsal horn, then maybe we can then try and restore normal processing of noxious mechanical stimulation and reduce the likelihood of mechanical hyperalgesia. With regards to looking in patients, I'm not aware of any studies that have actually been able to define these populations within human spinal cords other than using Golgi staining techniques from a good few years ago. It is very difficult have the tissue from post-mortem tissue in an appropriate condition that allows us to carry out these detailed anatomical studies. But that's something that I have tried to play with, but it is a challenge that faces us.
Thank you very much. Whitney, question to you. Is there any change in efficacy of the ACT program when it is face-to-face, whether it is provided by a trained psychologist or an AHP? And then leading on from that, is there a difference between the efficacy of the program between face-to-face provision and the online provision? Thank you.
Those are really good questions. And I guess we have slightly minimal and limited data to speak to that. There has been at least one sort of full-scale randomized control trial that has specifically looked at the provision of ACT, sort of low-intensity ACT through physiotherapists. That was the PACT trial, published maybe a year or two ago in Journal of Pain. And I think for the main outcome, which was something like pain interference or pain disability, there was a small impact. But that wasn't kind of directly comparing trained clinical psychologists or trained psychologists with other allied health professionals. And it may be sort of the relatively small impact was the low intensity nature of that treatment. So, I mean, that would be sort of a question that needs kind of direct comparison. In terms of directly comparing something like online ACT with something like our residential treatment program, it's really difficult. And I think that, I mean, you could do a randomized control trial to answer that question, but I actually don't think that that is going to advance the field, because in part, we need to better match people with the treatment that best suits their needs and their preferences. And I think people that are suited for online delivery and minimal therapist support in a self-directed nature are different from people that need more sort of intensive support, the full sort of interdisciplinary team. So I think sort of these head-to-head comparisons are not sort of the right question, and we need to look at these with different study designs.
Thank you very much. Barani, a question to you. Someone asked, have you got much information about the success of SCS after 2 years? And could you also just talk a little bit about the success of SCS in patients with spinal cord injury?
The question about the longevity of SCS, there are some published literature on the explant rates. That's probably one of the ways you could look at, and I think the explant rate ranges anywhere between 15 to 20%. Maybe it because of lack of efficacy, or the disease has progressed and they need further MRI scans that needs changing. And also within the field, there is talk about tolerability and whether there is something that we can do to really stop that habituation of stimulation. Hence, I think the whole industry is moving towards having some altered way of stimulating to make sure that that habituation doesn't happen. Our local experience, we've been implanting since 1995. We currently do probably about 180 to 200 cases a year, and our explant rate is less than 10%. And from 2012, most of our systems are paresthesia-based, paresthesia-free systems. So in essence, the patients don't feel anything, but they still have to recharge the battery once a week or once a day or once in 3 weeks. And our explant rate is 10%. So my understanding is if we don't take them out, they're still using them. And we published our data with the longer term outcome. And I think the longest in our case series is about 6 years down the line. But on the whole, the answer is yes, it does work long term, but there is disease progression in some people where you might need further investigations and you might need explant because it's not actually working for them on the longer run, like any other medical treatment. The second question about spinal cord, that's quite an interesting area because I don't know how many of you know, but you probably have seen the robotics on how complete spinal cord transaction patients have been made to walk back again using spinal cord stimulation, and that was I think that has been published, and I think it's called Solo Trial if I'm correct. And for pain, I haven't really had a good experience, and that's because if there is no continuity in the spinal cord, then the outcomes are not as good.
Okay.
And it's not commonly practiced in the UK.
Brilliant. I'm afraid we're getting to time now. I'd just like to say that our speakers will be available in the networking lounge, but I'm afraid Dr. Whitney Scott will only be available for the next 15 minutes in the networking lounge. So I haven't been able to put all the questions to our speakers, but if you would like to ask them, please go there. I'd like to once again thank the three speakers for a really interesting talk. Thank you very much. Bye-bye.